that you're here with. Very glad that you all are here with us. And I think to get the meeting started, we are going to kick this over to Cabinet Secretary Eric Friedlander to welcome you and say a few words. Secretary Friedlander.
Thank you, Lisa. Commissioner Lee, I appreciate it. And I want to welcome folks to this first meeting of our Health Disparity and Equity Technical Advisory Committee. I know you've probably talked with some folks about what this committee does. And Medicaid is a big program. A third of Kentuckians, more than a third of Kentuckians, 1 out of every 3, receive their healthcare coverage through Medicaid, right about there. And that's a massive number, and it's a huge piece of healthcare in Kentucky. And we have in the cabinet set up what we call our the things that we're looking at. So just to let you know, this is a part of a broader strategy within the cabinet to make sure that we are addressing issues of equity in all our programs. So we have a vision statement that really talks about communities and individuals living up to their full human potential. We then have 5 values underneath that, supporting everything that the cabinet does. The first value, the first pillar, as I call it, is equity, actually racial equity. And we focus on racial equity to talk about the intersectionality of so many things that impact across the spectrum of the population in Kentucky. Our second pillar has to do with resilience. Some of you may know that I was the Chief Resilience Officer for the City of Louisville, best government title ever, for several years while I was working for local government. And resilience really was, that work that I was doing in Louisville was kind of the, what we would look at for who it is that we serve and the populations that we serve, and the thread that runs through all of that, which is trauma, response to trauma, secondary trauma, and really working on that within the cabinet. The third pillar, and it relates directly to Medicaid. We talk about our programs, Medicaid, SNAP, childcare, and all those kinds of things. And we always talk about that more as it relates to an individual, but not how it relates to economic development and economic support for our communities. You wouldn't have a healthcare system without Medicaid. You wouldn't have a childcare system in this state without our childcare program. How many more food deserts would we have if it were not for SNAP? So we talk about that in that context. And then how we support our employees here at the cabinet to get to living wage and things like that, those discussions that we have. And then the how do you get to health and wellness, which is the fourth pillar, unless you address the other 3, right? You can't have that discussion about health and wellness unless we're talking about it within the context of those values that the cabinet is trying to promote. And then finally, kind of the operational excellence piece, which actually, we could talk about this being a part of it. How do we build our systems internally to make sure that we're supporting the work that we say we want to do? So in the area of racial equity and equity in particular, it is how do we build these systems within our systems to make sure that we're supporting that value across our systems. And Medicaid, being by far the largest program within the cabinet, we need to have advisors. We need to have folks that help us look at our data, look at our information, challenge us as we talk about what it is that we can do better. So your role within a technical advisory committee, and essentially it is to advise Medicaid on issues related to health disparities and equity. This is what we bring you all together to do to help us with and how we address that. And again, make recommendations, hold us accountable, challenge us. That's what these groups are designed to do. So we invite you to do that. It is an important piece. We have within our equity pillar, we have folks who are developing racial equity plans for all of the departments in the cabinet. We have our health. You will hear from Vivian Lashley Bibbs later on, who is our director of our Office of Health Equity and Public Health. But this is a cabinet-wide initiative. And this is a reflection of that initiative. So I welcome you all. I invite you to give us your feedback, and I invite you to challenge us and hold us accountable as we work to make Medicaid as equitable across our system, not only for recipients, but for providers, as we possibly can. So thank you. I'm excited to begin this work with you all. And I hope that we all learn together. So with that, I will turn it back over to Commissioner Lee.
Thank you, Secretary. I'd just like to echo the words that the Secretary just said, challenge us, hold us accountable. Yes, as he stated, the department covers 1.6 million individuals in Kentucky right now. We believe before the public health emergency is over, we will even increase that number to 1.7 million based on the eligibility numbers that we are looking at on a regular basis. And we know that we have challenges when we deliver the health care to our members. We know that there are shortages in some of our workforce areas that we need to address. And we're hoping that you all can help us figure out what we need to do to increase those workforces, especially as it relates to health disparity and equity, both racial equity and regional. We know that some Medicaid members have challenges because they are not only living at or below the federal poverty level, they have many chronic diseases, they have multiple issues, healthcare issues. And one of the charges I think this committee can assist with also is breaking down those stereotypes and misperceptions of the Medicaid members. We know that Kentucky ranks about 44th in the health rankings across the nation, and that ranking does not include just only Medicaid; it's the entire state. And we're hoping that the work that this committee does actually spills over into other populations that we do not serve in Medicaid. All of those individuals who maybe have commercial insurance, and we hope that some of our work, again, is going to lift this entire state up rather than just the Medicaid population. But we do have lots of information, lots of data that we will be glad to share with you to help drive some of those policies or recommendations, those questions. We also work with a lot of our state university partnerships, and we've just embarked on a new project with several of our universities that specifically look at some disease states in the Medicaid population, and they also look at equity among the delivery of services on several of those projects. So again, welcome. We're very excited to have you help us and guide us to improve the health status of those we serve. And I think that we have quite a few staff on here from Medicaid that's going to help you on this journey. And I will kick this off to Senior Deputy Commissioner Veronica Judy Cecil to say a few words and assist with introduction of the rest of the Medicaid team. Veronica.
Thank you, Commissioner. And it's a pleasure to be a part of this and to work with you all. As they mentioned, we are here to support you. We're so grateful for this opportunity. And I look forward to working with you over the next months and possibly years as we strive to improve the program. I would like to then turn it over to Leslie.
Hello, I think we're going to go through our member introductions, or do you want me to go with go ahead and go with the state introductions first, Veronica?
Yes, let's have Medicaid introduced.
That's right. Okay.
Yep.
So my name's Leslie Hoffman. I'm the Deputy Commissioner for Medicaid, and I'm the champion for change in the Medicaid department. And I'll kick it over to Jody Allen.
Good afternoon, everyone. I'm Jody Allen, and I'm a behavioral health specialist with the Department for Medicaid Services. And I'm also one of the core team champions for the Racial Equity Initiative in Medicaid.
Hello, I am Angie Parker. I am the Director of Quality and Population Health within the Department for Medicaid Services. I look forward to hearing what you all have to say, and I will be talking about more about my division here in a little bit. Thank you.
Other Medicaid staff who'd like to introduce themselves? Dr. Terrio?
Hello, I'm Judy Terrio. I'm the medical director for Kentucky Medicaid.
Good afternoon. My name is Amy Richardson, and I'm the Director of Fiscal Management here within Medicaid.
Hi, I'm Jennifer Dudinsky. I am the Director of the Division of Program Integrity in Medicaid.
Hi, I'm Pam Smith. I'm the Director of Long-Term Services and Supports within Medicaid Services.
Hello, I'm Justin Derringer. I'm the Acting Director for the Division of Healthcare Policy and Division of Medicaid.
Okay, I believe that's all the Medicaid
Okay.
staff.
Okay, so we'll go ahead and move to the members, and for the members, I'll give out the names on our list and tell us your name and why you're here today, why you're participating. So first is Wanda Figueroa.
Okay. Hi, good afternoon. I'm Dr. Wanda Figueroa, and I am the president and CEO of River Valley Behavioral Health. So essentially, I'm a behavioral health provider. I am pleased that this committee came together to address these issues. I feel like I was born into this advocacy, and I'm both by my personal experience and the work that I have done over more than 20 years in behavioral health and healthcare in general. I think it's the right step to bring different community leaders to address these issues. So I'm very hopeful and look forward to working with you.
Okay, and next I have Thomas Bowman. Okay. Patricia Bautista.
Hi, good afternoon. My name is Patricia Bautista Cervera. I'm a physician and public health master's. I've worked for La Casita Center. I'm the health empowerment coordinator at this grassroots community organization that serves and accompanies Latinx community in Louisville, Kentucky. The migrant community is our main community, and I'm here to learn and advocate and support as much as I can.
Wonderful. Next, I have Marcus Ray.
I apologize. I'm on the road working funeral service today, but my name is Marcus Ray. I'm currently can you hear me?
Yes.
Yes. Okay. I'm the state president for the NAACP, and I'm excited to be here. I think a lot of times when these programs take place, they don't always make it out to all the communities. And so I'm here to kind of bridge the gap and make sure that the information and the services are received in the community like they're intended as this committee forms and puts together. Thank you.
Wonderful. Thank you. Next, I have Keisha Curry.
Hi, I'm Keisha Curry. I'm from Paducah, Kentucky, and I have been a Medicaid recipient. I'm currently working as a behavioral health consultant for a long-term care facility. And I am just excited about being a part of this board that I can advocate and add whatever input I can into this situation. I appreciate the opportunity. Thank you.
Thank you, Keisha. Okay, we have Janine Lubaya.
Yes, Lubuya.
Thank you.
Hi, my name is Janine Lubuya Mbela. I'm from Congo and an immigrant. I am a CNA, certified assistant nurse. I've referred many people to one of the members of Medicaid to help the immigrant find Medicaid and some medical assistance. So I'm glad to be in this committee to be able to advocate and bring some insight for the immigrant who are coming from other countries, especially French country. Yeah.
Well, thank you. Elaine Wilson, please.
I'm Elaine Wilson. I'm the Director of Diversity, Equity, and Inclusion for Somerset Community College. I'm also a student with the College of Social Work at UK in a doctoral program, which we mostly study issues of social justice. And so I am here to represent people who are caught in the health disparities and equity issues so that they may too have a voice and an advocate. Thank you.
Thank you so much. Roger Cleveland.
Good afternoon, everyone. As you said, my name is Roger Cleveland. I'm a professor in the College of Education at Eastern Kentucky University. And in the past, I've done a lot of work around education equity, but also know working in schools and universities, there's a direct correlation between academic achievement and academic disparities and health disparities. And so this interested me, and I'm here to support.
Thank you so much. Mr. Cleveland was the last on my list. If I've left anybody out, please speak.
I don't think we heard from Julia Richardson.
Yes, thank you, Veronica. Hi, I think I'm officially on the list.
Yes.
Okay, I'm crashing your party. I am Julia Richardson, and I'm a general pediatrician in Louisville, Kentucky. I have been a pediatrician in the state for almost 25 years, first in Jackson County and now in Louisville. And a great deal of my professional work has been around health disparities. Before we said the word racism, right? We just talked about disparities out of context and still do often. I am actively involved with our Kentucky Primary Care Association, which is the membership organization for community health centers and rural health clinics across the state, developing our work in diversity, equity, and inclusion across our systems, which is so important for our families and patients we work with. I work full-time as a pediatrician. 100% of my patients are covered by Medicaid. About 30% speak English. So I have a very diverse population, and I'm very interested and excited to work with these amazing partners. And I'm most interested in identifying the current policies and procedures that maintain the disparities, because I think when we try to work on disparities, if we're not at that level of depth, it's going to be hard to succeed.
Thank you so much. We're happy to have you as well. Sorry, Veronica, I'll turn it over to you for the committee.
I think we have one more. Yes.
I apologize. It's okay. Hi. Good afternoon. Katrina Bowman with Northern Kentucky Community Action Commission. I'm the executive director there. I've worked with community actions for over 20 years, working with this population and seeing how Medicaid has changed over time, and just excited to be a part of the conversation and look, as Dr. Richardson said, at the policies and the practices and how they impact our families. So thank you.
Thank you so much.
Okay, I do believe that's everyone.
Real quick. I believe
Jordan,
I should be on there too.
Yes, you are. You are. I'm sorry. Our
All
list is popping around. I apologize for that. Go ahead.
Making sure. I'm Jordan Burke. I'm a pediatrician in Eastern Kentucky at Primary Care Centers. I'm a general outpatient pediatrician, but also provide hospital coverage for like hospitalist newborn coverage at Hazard ARH. I'm just excited to learn from you guys and try to bring some perspective and advocate for more of the rural part of Eastern Kentucky and try to bring both differences and similarities from kind of things we're trying to overcome and help people with. So, yeah.
Thank you. And I could, I think that is everyone. Sorry, the list that we have, when we move it, it loses people. So apologize for that. Thank you, everyone, for, what we tried to do in creating the committee is to bring lots of diversity, both racial, gender, geographic. And so I don't know if you noticed as everyone was introducing themselves, we have tried to gather people from throughout the state and in the different areas. So we're very excited about that. That doesn't typically happen. So we were very intentional about that. I wanted to talk a little bit, this is a brand new TAC is what we call it, Technical Advisory Committee. We do call them TACs. Medicaid has a Medicaid Advisory Council that's created in statute and mandated actually in federal law. And so we have in Kentucky statutes, a Medicaid Advisory Council, and also in Kentucky statutes, we have various technical advisory committees. This committee was created by executive order, as the secretary mentioned, and so it is a little different, but what we're hoping is that we connect the work that you all do to what is going on with our Medicaid Advisory Council, because we think that this is a piece that's sort of missing from the conversations that happen with our other TACs. And so we're going to see how we can bridge that, the work that you're doing, into the other work that's going on. We recommend, and so we are here to serve you all, and this is your committee. We'll make recommendations, but certainly want you all to make the decisions on how you want to operate. We do recommend that in these initial months that maybe you meet at least every other month. We're going to try to be very mindful of everyone's schedules, and we're happy to continue this virtually if that's the will of the committee. And certainly we understand that that is very convenient right now. We've been able to do that throughout the pandemic for all of our MAC and TACs. They went virtual and they've remained virtual. And what we have seen is that participation has increased significantly as a result of that, both in achieving a quorum of the members, but also the public. So we've had a lot of great participation by maintaining a virtual presence. So we'll work with you all on how you want to meet, and try to, for those who are interested, we could even potentially do hybrid meetings. So if you want to come in to an in-person meeting, we would still offer a hybrid virtual option. So we can talk about that, but I think again, for the initial ramping up for this committee, we do recommend every other month. And so we'll continue to do that, but we'll definitely want your input as we schedule those. The other thing is that it calls for an election of a chair and vice chair. We kind of like to call them co-chairs. We anticipate a lot of work from this committee, and we understand that you all have your other day-to-day work that you're doing, which is amazing work and keeping you very busy. So we thought the election of co-chairs would then sort of maybe soften the load on one person and can offer as a backup when somebody's not available. So at the next meeting, you all can think about whether you want to nominate yourself for a chair or co-chair position. We'll take those nominations, and then at the next meeting, we will open it up for a vote of the membership. So to do that, if you are willing to serve in that capacity, what we do is ask you to send your self-nomination to Erin Vickers. I know you have her email address. She's the one who's been contacting you. And just make note of that. We'll send out a kind of final call for nominations prior to the next meeting. And as a reminder, and hopefully an encouragement for you all to do that. So that'll happen at the next meeting. The Medicaid Advisory Council and the TACs operate under their own bylaws. And so we recommend that for the structure of this committee that you all also adopt bylaws. We are going to share the MAC bylaws that we have now, and it basically, just kind of helps establish attendance and how the meetings are to be run, and just give some structure. So we'll share those bylaws with you, and upon election of co-chairs, then we can then discuss, what changes you all might want from those bylaws. And we're happy to help make those changes, and then we can present that at a meeting for you all to adopt. So we'll work on that, and we'll get those bylaws out to you all so you can review it in the interim. One of the goals of this committee is to make recommendations, is to help us identify what can we do differently, what can we change, what new things can we do. And so, we are going to ask that you all present some recommendations. Although you're not officially attached to the Medicaid Advisory Council, we are hoping that in conversations with the chair of the MAC, who is Dr. Beth Parton, that perhaps this committee could report up and present those recommendations to the MAC as well. But those recommendations are things that we're interested in reviewing and implementing and discussing. Several of you mentioned that you really want to look at the policies and procedures, and we do too. I mean, that's why we're here. We want to know what can we do different to break down the inequity, the barriers and the inequities and disparities that are across our state for our members. So, we'll continue to work through that process and just look forward to those recommendations. And then a report. So again, right now, the technical advisory committees that are established in statute report up to the MAC, and they provide a report at each MAC meeting. We'd like to see maybe a similar approach to have this TAC provide a report to the MAC on a regular basis. But for now, we understand, this is all new and very much in its infancy, and we look forward to working with you all to get you up and running and start really digging in to the data, digging into the information, having discussions, and sometimes probably very difficult ones to help move the needle for our members. So that's just a little bit of the committee structure. Does anybody have any questions about anything I said or how we're moving forward? I'm happy to take those.
Hi there. One question I have just about the recommendations. You said they'll go up to the Medicaid Advisory Council, and then what will happen from there with those recommendations?
Well, wonderful question. Because you're not an actual TAC in statute that reports up to the MAC, it's just really sharing that recommendation to them. The way that process works is the MAC will endorse the recommendation, and then we'll respond to it within 45 days. We're not really going to be beholden to that process. And instead, we'll take those recommendations directly, but we will provide, response to that. I think, your recommendations are deserving of that. So we'll take those and consider them, and then follow up on them to provide, is it something that we can do? If it's not, what are our barriers? But that's a great question. Any other questions just about kind of the committee structure?
Yeah, this is Julia. Is there a plan to have this in legislation as well?
I believe there is. I don't want to speak ahead of anyone, but I think our interest is that we do get it into the statute so that it is, something that will continue on regardless of administration.
Yes, this is Eric Friedlander. That is our plan. We proposed legislation last time. It did not get introduced. We're going to propose legislation again this time. Hopefully it will be introduced and get through the General Assembly process. And I want to echo something that Veronica said there, which is with the MAC, with the TAC, even this statute, all these recommendations will come to Medicaid, including the recommendations from this group. And we do respond to those recommendations about what's possible and what's not. And that's the structure of the MACs and the TACs, even the ones in statute. So I just want to be clear on that. You all are not, this TAC is not in any way doing anything differently from the work of the others.
Any other questions? Okay. Well, then it's my pleasure to turn this over to Vivian Lastly-Bibbs, Director of the Office of Health Equity for the Department for Public Health, who's going to give us a statewide equity update.
Well, good afternoon, everyone. I'm going to try to share my screen, and hopefully you'll be able to see what I see. And if you all can let me know if you see it, that would be helpful.
We can see it.
Can you see it? Great. So is it advancing? That's the next thing. No?
It advanced. We now see the Kentucky Office of Health Equity was established in fall 2008.
All right, great. I do apologize. I've got 3 screens and different monitors, so my system gets a little slow sometimes. So that's why if you all let me know if it's not advancing, that'd be helpful to me. Just a little background about the office for those of you who don't know me. Some of you in this group do. Our office was officially established in 2008 by our former Commissioner William Hacker, who kept saying, we talk about disparities, but we really don't look at the why and what's causing those. So he established what was called at that time the Center for Health Equity with some state dollars within public health to fund that office. From 2008 to 2010, that's how that office was supported. Moving forward, 2010 through 2016, we were supported from federal dollars from the Office of Minority Health and HHS, and then other smaller grants along the way. And from 2016 moving forward, our office has been supported by the CDC Public Health Block Grant. Currently, we've been in an opportunity to do some really exciting work in the Office of Health Equity, being a recipient of a CDC Health Equity grant to do some work with immunization and vaccine uptake, and also addressing health inequities within our most vulnerable and marginalized populations. So we're doing exciting things in the office and building up our infrastructure and staff and really doing some exciting programming across the state. So our office really has what we call 5 areas, strategic areas that we focus on, which is always raising awareness around health equity, making sure that we have the latest and greatest research that's going out to translating and disseminating that to populations so they can understand it, and then making sure that if we're participating in some of that community-based participatory research, that we're always making sure that there's an evaluation component to it to show the impact of our work. We also do cultural humility and sensitivity training. We also work with our leadership so they can understand what a health equity, using health equity lens means. What does that health equity framework look like? How do we make that an underlying foundation principle in our strategic plan? How do we make that an internal part of our work? And then we also want to make sure that access to care is so important in the work within our health and health systems and the experiences that our communities are having within those. So just working definitions here, health disparity and health equity, I still find that people confuse the two. And I think Dr. Richardson hit it on it when she said we sometimes want to focus on the disparity, not realizing what drives that disparity, which are the inequities that are the what we call those root causes or midstream causes, root causes that impact communities. So the disparity is just we usually express that in a number or a rate, and it's a difference between individuals or groups that's unfair because it's been caused by some kind of social or economic disadvantage. And then health equity is attaining the opportunity for all people to have the greatest health potential. No one's disadvantaged because of their social position or socially determined circumstance. So just so we're all on the same page there. Disparate health outcomes have been linked to all of these. I don't have to read them for you. We recognize that a lot of those intersect. And then when we think about health equity, it exists across many dimensions as well. Race, gender, ethnicity, social connectedness, sexual orientation. So when we talk about equity, you know, there's the rule of thumb. Some people want to see liberation at the end of this picture, which is where that fence is removed altogether. But right now I want us to talk about, when we talk about equity, it's not just about making sure that we provide some folks with what they need and figure that we've addressed the issue. That last box, that last figure is what I want to kind of focus on, is the reality of where people are, the reality of where people are finding themselves in community. And that's what our office is trying to raise awareness around, trying to get our folks to think about how that is impacting populations where we have public health programming and how we can connect across the cabinet to do better population health work. So by achieving health equity, the social determinants of health are those things where you live, learn, work, play, and even where you pray. And we want to address social determinants of health by using population-based interventions, using targeted methods that are focusing on the areas and communities that have the greatest unmet needs. And we need to do that by understanding those root causes. What are those upstream factors, those systemic, structural, institutional things that are either historically have impacted communities or have been put in place even recently that are driving that disparity gap even wider and perpetuating health disparities within our communities. So one way we do that is by looking at the Minority Health Status Data Report, and we're required by statute to produce that report biennially. And we have done that since the office's inception. We date back to 2011. The first one was done. What that document does is really kind of give communities, our external partners and our internal programming folks within the cabinet to see where those disparities lie and what is really impacting communities. And we have that. I don't want to belabor you with data because you're going to have people after me coming to talk about data, and that's not what we're here for, is to really just talk about all the information we capture, but I want you to know how that data is used. When we look at the Minority Health Status Report, it's kind of divided up into sections. We look at demographic data, we look at social risk factors that impact health, those health risk factors themselves, and those risk factors as they impact health and poor health outcomes. And I've listed the link to our webpage if you want to go onto our webpage and see the different reports that are there, see some of the work that we're doing in communities. So I hope you do visit our webpage. So just wanted to give you, I know this may be small to some, depending on what device you're looking on, but just to give you an example of what you might see in our report about the demographics we collect and talk about where most of our minority populations live and reside within our state. We talk about the makeup, the population. We talk about those social risk factors. We talk about healthcare. Your health outcome is solely linked to whether you're a home renter or whether you're a homeowner. Research has shown that. Other health risk factors, looking at populations that are overweight or obese. And we're also looking at disabilities within our state. 35.1% of adults in Kentucky have some sort of disability. And that's information that over the years we have begun to incorporate in our Minority Health Status Report, collaborating with folks outside of the Department of Public Health to be more comprehensive and then trying to be more inclusive and painting a broader picture of what's happening related to the health of our populations, and then health outcomes, of course. I don't have to tell you that Kentucky, you heard our health ranking of where we are with our health. I don't have to tell you that we have #1 in the country for lung cancer and other cancers within specific demographics. Also, we have a large percentage of our population, minority populations, with diabetes. So there are other things that you'll find there as well. But I don't want to belabor you with all the data. This is the slide that I like. So we get all this information we can, but I think we'll use it later. That's not what we want to do. What we are doing now is gathering as much information as we can and using that information real time to be able to do something to impact communities right now and not somebody else's job after we leave, or 10 years down the road, 5 years down the road. We want to use the information now. And that's why this group is so important, that we're pulling all of this information together for you to have a big picture of what's happening in population, the Medicaid population across the state. The different lenses that you bring, the different perspectives that you bring to the conversation, I think are going to be invaluable. And I also want to say where we are moving forward with equity. I'm proud to say that Secretary Freelander has really pushed all of the departments within the cabinet to look at racial equity, to see what we're doing internally, not only with health equity, but with racial equity as far as what internal policies we have, programs, structures, barriers, and challenges that we are experiencing as a department that would impede the work that we need to do, not only within our own agency, but how we do that work in our communities. If we don't understand it ourselves, we can't address it. We can't help our external partners understand the needs and give them the capabilities and tools that they need to do that equity work. So I love this slide when I talk about upstream, I'm talking about those policies that shape communities. I think about those things that impact community, structural racism, discrimination, all the other isms, classism, sexism, genderism, all of those things. And then I think we've gotten stuck in the midstream, which is talking about social determinants. We know housing and education and access to good paying jobs, livable wage, a healthy and living environment, clean air and water. We all know those things, but I think we've gotten kind of stagnant and really not wanting to talk about the real issues, which is the upstream. And I'm hoping this committee can really talk about some of those upstream things that impact health, because we focused so long on the downstream, just putting a Band-Aid on things and addressing some of those chronic conditions without really being able to close the disparity gap, because we're not having the harder conversations as to the why. So just want to leave you with that. To address the health disparities and address those inequities, we really have to come together. And I think that's what we're doing here, to address what are the real drivers, and then unjust circumstances, whether they're based on race, gender, income, ethnicity, social conditions, they all need to be eliminated, because everyone deserves the best possible health, regardless of their zip code, because we all know that your zip code many times determines your health versus your genetic code. So I'm hoping that I didn't go too fast, but I do want to be respectful of the other presenters after me. So I'm definitely going to be hanging around if you have specific questions pertaining to what I've just presented. So Veronica, I'll turn it back over to you.
Do we have any questions for Vivian? And thank you, Vivian. I know that this won't be the first time you present to this committee, so we look forward to your participation as well. Any questions for Vivian? If not, I will turn it over to Leslie.
Hello, I'm looking, I need to, Erin, can you allow me to share? It says host still has disabled.
I just made you a co-host, Leslie.
Thank
I'm
you.
sorry, I made Jody a co-host earlier. My apologies.
Oh, that's okay. Let's see. Make sure I've got the right one. Okay, can everybody see my screen?
Yes.
Okay, I'm going to leave it in this mode. I have the same problem that Vivian does, in that I have a delay with the 3 screens, and being remote. So I'm going to leave it in this mode if that's okay. Okay. So we've done some wonderful work here in the Department of Medicaid, and we want to just give a big shout out to our team. And I wanted to give you several updates related to our initiatives. Some of this you may have already heard related to Ms. Bibbs or Secretary Freelander's information related to the cabinet. So CHFS tasked DMS with creating a racial equity plan, and that would roll up to the big CHFS plan. So we all roll up to their pillars. That includes normalizing, organizing, and operationalizing. I think normalizing was one that we really recognized right off the bat in developing that shared language. That was a really big deal for us to get started with. Increase awareness, collect and disaggregate data. In organizing, we're going to conduct equity training, implement racial equity core group, and develop external partnerships. And then in operationalizing to develop the racial equity plan, use racial equity tool in decision making, and to determine accountability mechanisms. And this is kind of long, but I wanted to share it with you, and we've actually cut it down. We kind of developed what kind of our purpose and mission was towards this plan. So I want to read that. The Department for Medicaid Services is committed to becoming a racially equitable organization. Our work will include a focus on internal development as a single state agency serving 1.68 million Kentucky Medicaid members, as well as our external development in relation to Kentucky's healthcare continuum. Additionally, DMS will be an organization embedded in learning and cultural humility that encourages self-awareness and participation in the enhancement of racial and health equity. With the alignment of the pillars, we have equity, which is advancing our racial equity to promote an equitable and fair commonwealth for all Kentucky members. Health and well-being, which will eliminate inequity and that compromises the health and well-being of our Kentuckians, and to provide an equitable commonwealth for all citizens, regardless of race, color, religion, sex, national origin, age, disability, or genetic information. Structural economic support is support and serve Kentucky Medicaid members by utilizing DMS's financial management and reimbursements to Medicaid providers to leverage our racial equity practices and in turn yield immeasurable health and welfare gains for our Commonwealth. Resilient individual and communities to promote racial equity within underserved communities across the Commonwealth, to eliminate disparities and trauma and build resilient and thriving communities across Kentucky. Operation of excellence is to provide equitable services for all of Kentucky's members and to ensure that the health care needs and welfare of Medicaid members are met without inequities. DMS Racial Equity Enterprise Goal Themes. So these are our themes that we're working on currently and have been for quite some time in DMS. Number one is the use of a government alliance on race and equity GARE tool across all departments for accountability, racial equity in hiring, racial equity in procurement, and I will add other contractual agreements or MOUs that we may have. And number four is a Medicaid Innovation Collaborative. We call that MIC, and it's a state cohort participation. I wanted to tell you a little bit about that. We applied for this opportunity and we were chosen. We will be in the second cohort. The Medicaid Innovative Collaborative is a collaborative and a program that enables Medicaid programs to identify and implement market innovations that advance health equity and provide Medicaid beneficiaries with the opportunity to achieve their fullest potential for health and well-being. And as I said earlier, we were lucky to get into the second cohort, and the second cohort we will be partnering with New York and Nevada. Oftentimes lessons learned and other opportunities to hear from other states are really are good to make positive moves towards the future. Our area of focus with Nevada and New York will be social determinants of health. They have different cohorts, and we just happen to be paired with New York and Nevada with social determinants of health as it relates to health disparity and equity. So just some other things, and I don't have to go through all these, but because we're part of this cohort, and we did, by the way, reach out to our cabinet level folks and met with them to ensure that this all rose up to the pillars before we said yes about participating. It's to identify and define health equity priorities in Kentucky, to hear from beneficiaries through the original research conducted by MIC, review national sourced curated list of vendors informed by health equity priorities, beneficiary research, and MCO collaboration. Share these solutions with managed care plans, providers, and other key stakeholders in Kentucky. Receive technical assistance to change policies, incentives, and requirements to accelerate change, and to support our MCOs to identify and develop strategies to advance health equity efforts. The four main goals of the innovation group is community engagement, which is a special emphasis on lived experience of Kentucky beneficiaries, providers, and community members, collaborations which are shared best practices with other states, technical assistance, which is benchmark development, data, policy levers, and implementation support. Innovative strategies is to help states and MCOs meet new complex health equity goals. And with that said, I'm going to turn over this slide to Jody Allen, who's on with me today.
Good afternoon, everybody. I'm so glad to be here with you all. I want to share a little bit with you about what we're doing in each division area with regards to the Racial Equity Action Plan. So I just listed out for you all here the different divisions within DMS. And so Leslie spoke about the enterprise goals, which are the overall goals that all of DMS are working towards. But each division was also tasked with applying that health equity lens to look at their day-to-day operation and the work that they do on the day-to-day, and how can we enhance racial and health equity across the board and within our divisions. Next slide, please. So I just gave you an example here, a couple of examples of the goals. So all the divisions are creating these health equity goals and objectives using the SMART goal strategy. And so a couple of examples are the behavioral health team. DMS behavioral health team will incorporate equity language into all MCO contracts and behavioral health initiatives. And this is aligned with the procurement enterprise goal that was mentioned earlier. And in the pharmacy area, DMS will collaborate with MedImpact and Magellan to analyze pharmacy claims data with regard to race and adherence to medications within a therapeutic category. DMS will review a subset of pharmacy claims data and determine disparities among adherence rates with regard to race. DMS will coordinate with MedImpact and Magellan and review results from 2021. So this is aligned with the normalizing task in the DMS racial equity charter. So we're trying to, in all of our work together, we have the overarching enterprise goals and the charter that's guiding us, but each of our areas specifically are lining up with those. It's really been a neat experience to watch this come together across the board. I mean, every area is so different with regards to the day-to-day operations and work that's done. And it's just been a really cool experience to be a part of this. Next slide, please. So some of the initiatives that are in progress right now, we are working on the Government Alliance on Racial Equity Accountability tool, which we refer to as the GARE tool. Basically, this is a guided conversation. When I think of a tool, I don't think of a guided conversation, but it's an exercise so that each division sits down and talks through these guided questions. And really, honestly, it's just a way of holding our divisions and ourselves accountable and really being inclusive with all of the decisions that we're making across the board. So we're hoping that the full implementation of this tool, all divisions will be using this by the end of the year. And we are definitely on track for doing that and meeting that goal. Also, we have created a racial equity core team SharePoint site. So our core team has gotten together and we decided that we really needed to get organized and try to find ways to communicate with each other about our divisions and what we're doing, the ways that we're meeting our goals, sharing resources to help us reach those goals as well. So that's another thing that we've done that's been really helpful. Next slide, please. Also, we know that according to the CDC, and this is just one example of a disparity, but Black women are 3 times more likely to die from a pregnancy-related cause than white women. And when we think about maternal health disparities, we've got some really great news. In June 2022, recently, the Department for Health and Human Services and CMS announced that Kentucky's request to expand postpartum coverage through Medicaid and CHIP was approved. A handful of states were approved for this, which is just great news for all women in Kentucky. So now postpartum care for women is expanded from 60 days to 12 months following the birth of a child. So we're really, our hope is that we will be able to close that gap significantly with women in Kentucky. Next slide, please. Also, through the CCBHC, which is Certified Community Behavioral Health Clinic Initiative, is our way in Kentucky of attempting to integrate behavioral health and primary care for all Kentuckians, no matter race, ethnicity, or complex health profile. Just as Vivian had stated, that everyone has the opportunity for good health and health. So the CCBHC initiative is the way that we are working towards that in Kentucky, and that's ongoing. And we're really looking forward to getting some great data and seeing more how that's working in our state. Obviously, this is an initiative for, regardless of the ability to pay or payer source, for all Kentuckians. So closing the gap again on those health disparities in Kentucky. Next slide, please. Also, DMS is involved in the Mobile Crisis Initiative Planning Grant, and that is a way for Kentucky's effort to streamline and integrate and improve crisis response services across the state to all Kentuckians. Again, all Kentuckians. A component of the MCI planning grant is to be culturally and trauma informed, as well as reaching all people regardless of their ability to pay, regardless of the complexity or the nature of the situation that they're dealing with, regardless of race, ethnicity. So that's also definitely a way that we are working towards closing that gap as well. Next slide, please. So the SMI 1115 Amendment Initiative. Through CMS, we have the ability to apply for an 1115 waiver, which would allow us a little bit more flexibility with regards to offering services in our state, and to try out some new ways of providing care. And then we need to look at how did we do financially with that project or with those services, and how we did that differently. So we are applying for an SMI 1115 amendment through CMS, and in that application, we plan on including supportive housing, supportive employment, and recuperative care as community support services to address those social determinants of health. This is all pending CMS approval, of course, but we're really excited about this initiative and applying, gathering information so that we can really help people in our state to meet those social needs that they have in order to have better health outcomes. So the tentative application will be submitted to CMS December of 2022. Next slide, please. I'm going to hand this over now to Angie Parker, and she's the director of the Division of Quality and Population Health. She's going to share a little bit about the Equity and Determinants of Health branch.
Good afternoon. As Jody stated, and I told you earlier, I'm Angie Parker. I'm the Director of Quality and Population Health within the Department for Medicaid Services. And it's the creation of the Equity and Determinants of Health branch just started in July. So this is very excited. And this branch is within the Quality and Population Health. The areas of focus, and as you can see, we're already doing a lot of work in the cabinet and Medicaid, and this is another piece of that I'm very excited to be a part of. There was a reorganization in July, and this branch was added to Quality and Population Health in order for us to utilize the information from this TAC and other areas in which we can continue to improve the health disparities and equity and social determinants of health of the Medicaid population. So the three examples of the the important areas of focus. It was to assist with the implementation of the Racial and Health Equity Action Plan that Jody just talked about, and Deputy Commissioner Hoffman, to work to address racial and health disparities and enhance health equity for all of our Medicaid members, and to hold DMS accountable for racial and health equity initiatives. So this is in the early process, but we are in the midst of developing this and hiring staff, and we look forward to providing you all some additional information once this gets rolling a little bit more. Thank you.
And I am muted. I'm sorry. I'm going to go ahead and put up our contact information there. So that's Veronica and myself and Angie Parker and Jody Allen. And then I will go back if there's any questions. This will be made available to you. I know we've given you a lot of information today. Just as Jody said, though, each one of our divisions have been working individually. So at some point, if you want to hear about some initiatives from maybe one particular division, we can let you know. We've kind of just combined everything together right now for where we are. Our first real big milestone will be 12/31 of this year and getting all divisions to complete and finish the GARE tool. So, and this PowerPoint will be made available. I'll have ask Aaron to send that out to everybody on the call today. Any questions?
Hi, this is Julia. I don't know if this is possible, but just for the members of this group so that we can maintain sort of that big picture, is there any way to do kind of a driver diagram that has kind of everything on one page? I know it would be overly simplistic, but it would kind of be like placeholders for us to kind of put all the puzzle pieces together. I don't know if others would find that helpful or not, but you all are doing such amazing work. It'd be nice for us to keep it all in motion at the same time.
Yeah, I think we could work on some type of summary for you and let you know as we proceed along with our goals. Some of our goals, for example, the Medicaid Innovative Collaborative, which so far has been very helpful. It will go on for, it can go on for a long time, but I think we at least have them for 18 months. So you'll hear us talk about what we're learning in relations to those initiatives as we go to our meetings. Jody and I have participated in a couple of their spotlights and have been extremely helpful related to maternal health and youth with behavioral health issues related to health equity. So did I answer your question? And yes, I think we can come up with something.
If you have a specific format that you think would be helpful, I would be happy to take a look at that if you want to send it to me.
This is Elaine Wilson. Could we possibly have a blank of your GARE tool? I'd like to see what all that includes, please.
Yes, ma'am. What we can do is send you out a link. And Jody, I believe you have a short video that we've kind of been utilizing as well.
Yes, and that way, and the website information as well. There's a toolkit and some website information and a helpful video. Of course, love to share.
Thank you.
Thank you. So on the agenda, after a discussion and questions, we just had next meeting is November the 2nd. As Senior Deputy Commissioner Veronica Cecil mentioned, just for the committee to kind of communicate the needs and goals and tasks and election of the co-chairs.
I have two other questions. One is, can we get all of the 2023 dates set so we can hold our schedules? And then
I'm currently working on that schedule.
Okay. And then, and this isn't a question to be answered, but maybe to kind of come up over the time of our time meeting together. You know, I mentioned we've all been doing this work for many, many years. And we know more, we understand things differently now. So, you know, I think every decade is a new opportunity to really get to where we want to be. But I'd love to know from y'all's perspective, and even the perspective of the members of the committee, why aren't we there yet? You know, what are some of those things? I think we know a lot of them in our head, but articulating those and really naming those, I think would be really helpful for me to know where people are and thinking about this work, and it might help us go deeper with our recommendations more quickly and move forward more quickly. So that's just something to throw out for future conversations, just like why are we still talking about this, right? You know,
Right.
But if it was easy, we would have moved on and be more equitable and have improved health for across the state. But so that, and then just always like being inspired by other people, you know, in different states. If there are some examples of situations, or whether it's big P policy or practices, or across the country where people have been able to achieve some really good successes in improving disparities.
Okay, and I think Jody and I could work on that. We could reach out to the collaborative that we're working with now. If you're interested in other states, I know there's been at least Hawaii, Arizona, West Virginia, and I want to say maybe Ohio. I can't remember the other one, but they've all had like what they call spotlight report outs, where they've told what they learned and what they still need to work on, and the good work that they have done. So one of the issues is that I feel like for Medicaid, since we serve 1 out of 3 and Kentucky members, and it's 1.68 million, that's a lot, right? It's identification and finding where those areas are that we need to address and make things better. So,
you know, Dr. Richardson, along with that, if you all know of bright spots going on in a community somewhere else, both in state and out of state, you know, we want to hear about that, and you know, how can, you know, what can we learn from that, and how can we tailor that to our residents? I think we have to recognize too that you know, one shoe doesn't fit all, so we might have to develop you know, actions that tailor to individual communities. And we've not, I think that's part of our problem is, as a state agency, we don't always do that. Some of that is we have limitations, but we should talk about it and we should consider it. And so maybe we, you know, the shoe size for a rural area is not the same shoe size for an urban area. And even among 2 rural communities, the shoe size isn't the same. So we would love to have those conversations with you all, because you are in the communities and you're across the state. And you know, we would love that perspective. And again, if you all have those bright spots that are going on either in the country or the state, we'd like to highlight those and have those conversations.
So as Veronica mentioned too, if you have needs that you'd like to address with us, like a few things you've come up with today, but as we move forward, you can reach out to us and let us know what those needs might be, whether it be you know, data or an easier diagram to follow, or anything like that. We'd be happy to work with you.
We're going to get a copy of the presentations.
Yes.
So we could go over and kind of reflect on it and give some feedback maybe.
Yes, I think we've got at least 3 things or more to send out. We'll send the GARE tool, the video. I think we've got a simple tip for GARE tool, and then we'll also send you the presentation that we just gave. And then we'll work on something simpler, maybe a summary of some sort of how we can show you what Medicaid has going on. Again, if you in the future want to look at any of the specific divisions, or we could probably ask sister agencies too, if you'd like to hear from another agency besides Medicaid.
You mentioned earlier that the MAC hasn't maybe spent as much time on these issues in the past. Did I understand that correctly? And do you have any thoughts on why or sort of what's going on there?
Go ahead.
I'll be happy to try. I will tell you that the first discussion about equity and specifically racial equity at the Cabinet for Health and Family Services occurred in February of 2020. So though that acknowledgement, that work began then, which is a shame, but it's true. I will tell you, while we were in the midst of COVID and we were seeing health disparities in terms of outcomes, I was sitting in the governor's office and he turned to me and he said, well, Eric, you need to fix that. And of course, my answer there is, okay, understanding all the complexities, but it is something we need to work on and we need to work on together. And my response to why haven't more Medicaid programs across the country been very specific in their approach to health disparities, particularly racial health disparities, is exactly because Medicaid programs are so big. And when we talk about systemic and institutional racism and structures, we need to be cognitive of the narrative, the pushback, the divisiveness of political environments. And so all of those things are real. It's all real, but we have work to do. And that's what I hope we will do together. And Medicaid is a giant system, right? That reflects the systems within which we exist, the healthcare system. All of those things are still reflected within our programs and systems. We need to work to make sure our systems are not perpetuating, preserving, and assisting what has been institutional and systemic issues across the Commonwealth.
And I think I would add to that, as the Secretary said, Medicaid is a huge system, 1.6 million individuals served in Kentucky right now. And how do we use our data? That's the other question that we need to ask. And how do we get reports out into the communities, into the hands of those individuals who can help us look at that information on our claims system to say, here's what we see is going on. Sometimes it's very, we can pull claims and pull reports all day long, but unless we get them to a level that is consumable, that individuals can actually look at and understand, it's a little bit difficult to make those changes and to know what to look for. So I think that that's one thing that I'm very excited about this committee is, I think that the variety and the expanse of individuals that we have on this committee is going to help us look for those or identify specific reports that we need to start looking at as we go forward. And also, individuals complete a Medicaid eligibility application, and race and ethnicity is not a required field. So our eligibility information is not quite complete to be able to tease out some of those different race and ethnicity of the individuals enrolled in Medicaid. So that's another issue that we can definitely look at. Can we get to that information on our claims data? Most likely we may be able to get to it, but I think that's the other question we need to answer is how accurate and how complete is our data, our eligibility information for the individuals that we serve, and how do we get that to be more complete and more accurate?
I think along those lines, we've not really had the resources or support to be able to do it. We're typically, like you all, our day-to-day is so, overwhelming at times. It feels like we're on the defensive more in just trying to keep people covered. But now with the support of this administration, with things going on at CMS. I think with expansion of diversity, inclusion, and equity, both at the community and corporate level, has now given attention and the ability to provide the resources necessary to take a look at this and focus on it. So, I would say that the MAC and TACs have been primarily focused on that, day to day, how do we just get services to people and how do we keep them covered? But now we're able to spend a little more time and which, is necessary and has been necessary for quite a long time. But now we have the resources and the structure with our reorganization to devote that attention to where it needs to be.
And we have leadership support too, is massive amount of having that support to be able to, when I first came back to the cabinet after a brief retirement, one of the first questions the secretary asked me is, how do we improve the lives of those we serve? And that's the question that we need to continually ask ourselves as we move forward. And it's not, we don't break that out by race, by ethnicity, by gender. It's everyone. How do we improve those lives? But we know that there are disparities in the delivery of healthcare in the state, and that's what we have to identify and break down those barriers and make sure that we are serving everyone that it's rolled in Medicaid and improving their lives in an equitable fashion.
Sorry, I keep asking questions, but it would be helpful for me and probably all of us to know what are the tools that we have at hand. So, for example, asking for a common PIP, or like asking for data reports. Just talking about that at some point would be helpful, I think, to help us know what is it within our area of influence, and what are some of the typical tools, and then we can be creative beyond that. But I know there are mechanisms within Medicaid that changes are made typically, and so understanding those in a really comprehensive way, I think, will help us be effective.
I have a question, and I don't know if this is the right time to ask the question, but it's more of a reaction to an information that was presented. And it has to do with what is the role, or what do you think is the role of managed care companies in advancing health equity? Because once a person, let's say, is covered through Medicaid, and I agree, it's very complex. The Commonwealth is hiring these managed care companies to determine what services are appropriate, whether they should be receiving services and for how long. And I saw something about supporting MCO managed care companies in all of this. And frankly, as a provider, I see them as more part of the problem than the solution. So I don't see, we spend an extraordinary amount of time trying to get people authorized to receive services. And so, and that is impede access to healthcare. Also, the disparity in how behavioral health care providers are treated, of course, versus primary care. And so that adds to the problem when we don't make them accountable. And so I don't know if their contract has some teeth that will require them to report on that or being part of the solution.
This is
They
Leslie.
have an extraordinary level of influence. And I think, I'm sorry, go ahead.
I'm sorry. I was just going to mention, and I didn't mean to cut you off. I apologize, that we are currently working on that now and have drafted language to add into the contracts. One of our enterprise goals is to add language into all contracts, policies, procedures, procurements, and everything going forward. RFPs, anything like that will include language to hold them accountable. Part of the problem, even with other states as well as ours, is trying to figure out how to get the information. So that's one of the things that we've already identified and asked the collaboration to help us with. Tell us how other states who are MCO states are able to get this information and to get those reports accurately and timely for us to use, correct? So those are the things that we're working on. We have like enterprise goals, and then we have the Medicaid Innovative Collaborative that is helping us to identify that with the MCOs. And like I said, last week, we worked on contract language. So the complexity is mostly, I think, with the making that identification. So a lot of times we're trying, if you heard me mention in the collaborative, we have abilities to get to other databases, large databases, and how did they extract that information and those kind of things. So we're hoping that all of that will be identified, but that is one of our goals to work on, our enterprise goals.
Good to know. Thank you.
I would add couple of other things. One is the managed care organizations should be concerned with population health and specific population health. And we need to continue to make that an expectation of ours so we can see improved performance. On the behavioral health side, we have taken off and kept off prior authorizations relative to behavioral health, but outside some of the purview of Medicaid, we know we have to have and promote more diverse candidates to become behavioral health providers. So the Department for Behavioral Health is working on providing additional training and additional support so that we can have the diversity within our provider population that then it is a better reflection of the population of the state. So there are other initiatives outside of Medicaid, which we can talk about here as well, that need to be a part of the overall discussion. So I think that's an important piece to remember.
Thank you.
You mentioned authorization of services. I know Dr. Terrio, our medical director, has been working with both cabinet level medical directors and the managed care organization medical directors to look at, prior authorizations. What service is being prior authorized? Is that necessary? And trying to dig into that a little more. Examples are always helpful to us. So if you have specific examples of services that you believe it's creating a barrier, this is exactly the forum to talk about that. So that we can take that back and really have a conversation about have we created a barrier, an unnecessary barrier to a service. So those are the things that we would love this committee to take up and have those conversations about. And in terms of what can you all affect, well, you don't ask for it, you don't know, right? So, if you all identify things and make recommendations, that's what we're here for. We want to move the needle for our members. We want to address those inequities and disparities, and we can't do that unless we have some, expertise to help guide us on how to do that. And so, I think pretty much everything's on the table in terms of what is it that you all think we need to do as a system, as a Medicaid program. We're certainly interested in hearing that, and the data, whatever data you need to determine that or to help inform your work, we can work with you on that. We want to make it available to you. So anything that you think you might need, we're happy to try to get for you.
So no, traditionally TACs aren't encouraged to talk about fee schedules and money and payments, but we all know that often, say for example, I have a long list of children who have rampant caries that need oral surgery, and they're being scheduled in December and January because access is an issue. And ask about access, they say that the payment issue is the issue, and that's why we can't get these kids with very serious illnesses treatment. So is that off the table for TAC discussions, or how do we handle when really we find that it's say a provider payment issue?
Yeah, I don't think it's off the table. And in fact, those conversations are going on right now in some of our TACs. We're doing a deep dive right now into dental rates and services. And I know one of the problems is workforce. So, you know, I think there's like 80 oral surgeons in Kentucky. That's a workforce issue. So, you know, I think it's definitely on the table for you all to discuss and provide recommendations on.
And I think definitely on the table. And when we look at those fee schedules and those rates, a lot of times it's just a request to do a wide sweeping across the board raise. But is there something else that we can focus on? Is there one service that's missing that would help? Is there one code that we need to look at, or a couple? And as Veronica said, we have about 80 oral surgeons in the state. That's not Medicaid enrolled. That's just 80 oral surgeons. We have a really good dental presentation that I'd be more than happy to share with you all related to where the access issues are as it relates to dental. But then again, when we look at the dentists in the state and those that accept Medicaid, it's higher than it is in other states. Our reimbursement schedule for our dentists is for our children is approximately 105% of commercial insurance. And also only 50% of the individuals in this state have dental insurance. So there's another issue. So we just need to figure out the workforce, because when you have two teaching schools that only graduate, I think 250 dentists a year, and most of those out of state. How do we find, recruit, and retain providers within the state? And what is it that we can partner with? Because it's not just a Medicaid issue. It's a state issue, because we rank, I think, 47th or 49th in dental care, and that's this entire state. So what other areas such as that, you know, the dentists who are graduating, and why are they moving out of state versus staying in? And what can we do to increase the number of dentists that actually graduate from our teaching schools is I think some questions that we can ask. But definitely, yes, rates and fee schedules and covered services, definitely a discussion on the table.
Thank you.
Okay, does anybody have any other questions or discussions or comments?
We're very excited about the work that this committee can help us with. And again, you know, we are here to help gather reports, look at information for you to be able to make recommendations for improvements. And we look forward to working with you to just give you the tools that you need to help, as the secretary said, help us be accountable and transparent. So again, just reach out and let us know as we go forward with future meetings, what it is that you think that we could look at as far as our claims data and our enrollment information, that we can start pulling data for you all to look at and help us be transparent and accountable for our members and our providers.
Yes, thank you for joining us to really improve the healthcare of all Kentuckians, and to reduce the disparities that we see across populations. It should not be, and we need to do everything we can to make it not so.
Yeah. Thank you.
And I think those are perfect words to end the conversation today. Thank you, Secretary.
Thank you all.
Thank you all.
Thank
Bye-bye.
you. Have a good day. Bye-bye.
Thank you.
Thank you.
Thanks, everyone.
Mm.